Anaphylaxis is an essential need-to-know topic. It is very important and it means life or death for patients, so we need to know about it. Usually we're taught this topic by memorizing lists rather than appreciating the pathology, how it comes about, and why we use certain drugs. Anaphylaxis is a severe systemic hypersensitivity reaction. Systemic here means that it occurs systemically, so occurs throughout the body. It has a rapid onset, so this is usually within seconds to minutes, and is characterized by life-threatening, this is very important, airway and or breathing and or circulatory complications and clinical features. And we'll come to discuss these shortly. It is also usually associated with mucocutaneous changes. So you can be confident that the patient is having an anaphylactic reaction when the three criteria are met. So these are sudden onset with rapid progression, usually within minutes. Second, life-threatening features including airway, breathing, and circulatory problems. And third, the presence of skin or mucosal changes including flushing, urticaria, and angioedema. So let's talk about the pathogenesis. This is to give you an understanding as to why the clinical features appear and how we can treat anaphylaxis. So anaphylaxis is a type 1 hypersensitivity reaction. We won't discuss the hypersensitivity reactions in this video, but just to refresh your memory, type 1 is first. So 1 is first, and you can think as the F as fast. So 1 is first, thus it is fast. So type 1 hypersensitivity reactions are fast. They occur within seconds to minutes. Now we use the mnemonic ACID, ACID, to remember the different hypersensitivity reactions. So this is type 1 hypersensitivity, type 2, type 3, and type 4. Now the A here stands for allergic. The C stands for cytotoxic. The I stands for immune complex. And the D stands for delayed. So these here are the types of hypersensitivity reactions, type 1, type 2, type 3, type 4, and this mnemonic is used to remember the mechanism by which they occur. So anaphylaxis is a type 1 hypersensitivity reaction and is the result of an allergic reaction. So the patient is allergic to something and this causes a reaction. So let's go through these steps. First, the patient is exposed to the allergen. This here is the allergen, and the allergen binds to the preformed IgE antibodies. And these two bind, forming this complex here. So what happens next is that the complex binds to the high affinity receptors on different blood cells, including the mast cells and the basophils. Now this receptor is also known as the Fc epsilon Ri receptor, but what you need to know is that the complex binds to receptors on mast cells and basophils. Now the binding of this complex to the mast cells and the basophils causes activation of the cells, and activation of these cells results in their degranulation. So this means that they release their contents. So they degranulate. Now when these cells degranulate, part of their components are the preformed mediators, such as histamine, very important, and various proteases. Activation also results in de novo synthesis of many inflammatory mediators. De novo means that the cells synthesize brand new inflammatory mediators as they are activated. Now there are many potential mediators of anaphylaxis, including histamine, platelet activating factor, leukotrienes, etc. But here we shall be focusing on histamine, as histamine is a very important preformed mediator that is released when cells degranulate. Now importantly, when mast cells degranulate, they release a substance known as tryptase. Tryptase can be measured to confirm a diagnosis of anaphylaxis. Now you can ask, well, if histamine is released in such vast amounts and is responsible for the majority of the clinical features, why don't we just measure histamine? Well, blood histamine can be measured to diagnose anaphylaxis. However, detecting histamine in the blood is very difficult due to its extremely short half-life. Also, histamine is not specific to a single cell. It can be produced by multiple cells. Tryptase, on the other hand, is more stable than histamine and is considered to be a mast cell product or a specific mast cell product. Now, before we discuss histamine and the clinical features of anaphylaxis, it is important to note that the pathogenesis of anaphylaxis is complex and multiple other systems are activated. Another important system that is activated is the complement system. So complement is activated in response to the allergen stimuli. Activation of complement results in the production of small polypeptide inflammatory mediators known as anaphylotoxins, and these are C3A, C3B, and C3C. Now, importantly, the blood levels of these anaphylotoxins correlates with the severity of anaphylaxis. Now, these work by activating the myeloid cells, and these include the mast cells and the basophils. Now, back to histamine. As we mentioned, histamine is one of the most important preformed mediators of anaphylaxis. Histamine is formed in most tissue and is present in high concentration when the tissue is exposed to the outside world, for example in the skin, lungs, and gastrointestinal tract. Remember, we said that histamine is released from mast cells and basophils in response to stimuli, including an allergen and complement activation. Now, there are 4 known histamine receptors. These are H1 to H4. And if you're interested in pharmacology, these are all G-coupled protein receptors that modulate a cAMP downstream signaling pathway. Now, importantly, all 4 receptors are involved in an inflammatory response, hence why we take antihistamines when we have, for example, sinusitis. Now, the clinical features of anaphylaxis are mediated mainly by histamine 1 receptors, hence why histamine 1 receptor antagonists are commonly used in the treatment of anaphylaxis, as we shall see. Studies have shown that aerosol administration of histamine causes bronchoconstriction, and IV administration results in the clinical features of anaphylaxis, including cutaneous flushing, headache, airway obstruction, and hemodynamic changes, including hypotension and tachycardia. So let's look at the clinical features of anaphylaxis. Remember, we mentioned that if a patient presents with this criteria, you can be certain of a diagnosis of anaphylaxis. So this includes clinical features involving the airway, breathing, and circulation, as well as mucocutaneous changes, including flushing, urticaria, and angioedema. To understand this, you need to know the effects of histamine. So let's discuss that. Let's start with the smooth muscle. Histamine 1 receptors are expressed in the smooth muscle of the bronchi, bronchioles, gastrointestinal tract, and uterus. When histamine binds to the histamine 1 receptors of smooth muscles on these organs, it results in contraction. And we can appreciate this from this diagram. So here we have smooth muscle, for example, on the bronchi or the bronchioles. Here is the histamine 1 receptor, and here is histamine. When histamine binds to the histamine 1 receptor, this results in contraction of the smooth muscle. So from this, we can appreciate what will happen in the bronchi and the bronchioles. The bronchi and bronchioles usually have a nice, happy, high caliber airway. Histamine causes contraction of the smooth muscles that line the airway, resulting in a small caliber, unhappy airway. Now, this can result in the patient suffocating, and this is one way in which the airway can become compromised. Moving on to the cardiovascular system, activation of the histamine 1 receptors in the blood vessels results in two things. These are dilation of the blood vessels and increased permeability of the postcapillary venules. So let's take a look at this. Normally, a blood vessel is able to adjust its diameter to maintain peripheral vascular resistance and thus blood pressure. So this blood vessel here is able to regulate its diameter to maintain peripheral vascular resistance. Remember, the equation for blood pressure is BP, blood pressure, equals cardiac output times systemic vascular resistance. So if the blood vessel dilates, it increases in size and thus decreases peripheral vascular resistance and thus decreases blood pressure. So this is very important. Histamine causes dilation of the blood vessels, which results in decrease in peripheral vascular resistance, which in essence is systemic vascular resistance, and this in turn results in decreased blood pressure or hypotension. So this is one mechanism by which anaphylaxis results in hypotension. The other way is via increased permeability. So let's take a look at that. Remember that blood vessels are lined by endothelial cells and that these cells are held tightly together by adherent junctions. Now, binding of histamine to the histamine 1 receptor increases the permeability of the blood vessels. So what we have here is that fluid can leak out of the blood vessels into the extravascular space. So this here shows that we have increased dilation as well as increased permeability of the blood vessel. Now, increased permeability is a normal physiological response. If, for example, there is local infection, histamine increases permeability of the blood vessels and allows white blood cells to travel to the area of infection. However, if this occurs systemically, with increased permeability of all post-capillary venules, you can imagine how this can get out of hand. Now, the consequence of this is twofold. First, you're going to have a decrease in intravascular volume. So the fluid inside the blood vessels escapes to the extravascular space, thus you will have a depletion of the intravascular volume. This is the second way that you can have a fall in blood pressure and thus hypotension. So the first way was dilation, and the second way is by increased permeability. So this here can also decrease blood pressure. Now, importantly, this here can result in anaphylactic shock. And this means that the circulatory system cannot deliver sufficient perfusion to organs and tissue and thus fails to meet the metabolic demand of the body. So with movement of fluid from the intravascular space to the extravascular space, there is less fluid inside the blood vessels to perfuse organs. Now, secondly, movement of fluid into the extravascular space results in swelling. And this is why when you picture a person who has had an allergic reaction, you picture a swollen person, so it causes swelling. Now, if the swelling occurs in the pharynx or the larynx, this can compromise the airway and suffocate the patient. Now, histamine can also bind to the histamine 2 receptors within the myocardium, increasing heart rate, so causing tachycardia, and increasing cardiac output. So now we have discussed why we get the life-threatening features involving the airway, breathing, and circulation. Let us look at why we have the skin and mucosal changes. Now, histamine 1 receptors are also expressed on the skin, and this results in vasodilation and increased permeability of the blood vessels near the skin. So vasodilation results in reddening, and this is a classical feature in anaphylaxis, as well as increased permeability, which results in urticaria. These two occur through the same mechanisms that we have described. Now, histamine can also attach to the nerve endings within the skin, resulting in an itch. So now that we have an understanding as to how the clinical features come about, we can list and understand the clinical features of anaphylaxis. Now, I don't particularly like this picture, but it's the only one available online, and I didn't just want to list different clinical features. So let's take a look at this picture. Remember, respiratory and cardiovascular are the most important, and everything else occurs secondary to cardiovascular and respiratory problems, as well as the inflammation that results secondary to the pathogenesis. So let's look at the respiratory. Remember, histamine causes bronchoconstriction, so we get features such as shortness of breath, wheeze and stridor, as well as hoarseness. Histamine also increases permeability, so we get swelling. Swelling can result in pain on swallowing, as well as cough. Now, the swelling can also worsen these clinical features. In the cardiovascular system, we have vasodilation and increased permeability. This reduces the peripheral vascular resistance and depletes intravascular volume. So remember, we have decreased peripheral vascular resistance and decreased intravascular volume. So we end up with a low blood pressure or hypotension. Now, the heart rate can be tachycardic or bradycardic, so fast or slow. Initially, the heart pumps faster in order to compensate. However, with decreasing intravascular volume, there will be nothing for the heart to pump. So this causes a bradycardia. So a bradycardia indicates a very serious situation. The patient's blood volume has significantly decreased and needs urgent resuscitation. Now, in the skin, we have the same mechanisms. So vasodilation and increased permeability results in flushing as well as hives, and the itching is due to histamine binding to the nerve endings. Now, everything else occurs secondary to the cardiovascular or respiratory complications as well as inflammation. So swelling in the conjunctiva, again, we have increased permeability, so fluid moves into the extravascular space. A runny nose, again, increased permeability. A runny nose suggests that there is progressive involvement of the respiratory system, so it is important to note. Swelling of the lips, tongue, or throat is also important, as it links with the respiratory system and can compromise the respiratory system, and the patient can suffocate. Now, patients can become lightheaded, lose consciousness, confused, or develop a headache, and this is secondary due to hypoperfusion. Remember, we have decreased intravascular volume, so there is less blood going towards the central nervous system. This results in these clinical features. So hypoperfusion as well as hypoxia. Remember, because the airway is compromised, less red blood cells are becoming oxygenated. So less oxygenated blood is being delivered to the brain and the central nervous system. Anxiety is secondary to the patient's fear, apprehension, or even disorientation. Now, anxiety can also be triggered by adrenaline or epinephrine, so during the treatment of anaphylaxis, and we'll come on to that. Patients can also present with pelvic pain or gastrointestinal pain. Gastrointestinal abdominal pains associated with nausea, vomiting, and diarrhea suggest an allergen has been ingested, and this is important to note because you might refer the patient for an allergen test and warn the patient of the allergy. Gastrointestinal and pelvic pain can also be secondary to hypoxia and hypoperfusion. Now, patients can also present with chest pain, so let's write chest pain here, and this is due to the hypoxia and the hypotension. So hopefully this has explained to you why the patients present the way they do and what clinical features you should keep an eye out for. By now, you should have a firm understanding on the pathogenesis of anaphylaxis and how the pathogenesis results in these clinical features. So usually the first features to appear are erythema, so flushing, urticaria, so hives, as well as angioedema, most commonly in the eyes, as well as the lips. Moving on to investigations. Now, anaphylaxis is a clinical diagnosis, meaning that you don't need an investigation to diagnose anaphylaxis. Hopefully by now you should be able to look at and promptly examine the patient and know whether they are having an anaphylactic attack and initiate urgent treatment. What you can do is monitor the patient. For example, check the patient's oxygen saturation levels, and this will reflect whether the airway is patent. An ECG, especially if you're treating the patient with adrenaline, patients can develop non-specific ECG changes and arrhythmias. Blood pressure, to monitor whether the patient is going into shock, and a blood gas, to check the patient's pulmonary function, and if the lungs are adequately oxygenating. It might also show an elevated lactate level, and this is secondary to metabolic acidosis that results from poor oxygenation and perfusion. Now, if you want to confirm a diagnosis, you might consider doing a mast cell tryptase during or after resuscitation and treatment, so you should not delay treatment. Remember, we said that mast cell tryptase is more stable than histamine and is more specific to mast cells. Moving on to the management of anaphylaxis. Now, anaphylaxis is a medical emergency, so if you're by yourself, call for help. Always call for help. Now, if the patient is in cardiorespiratory arrest, initiate CPR. Now, if the patient is in cardiorespiratory arrest, you should not give intramuscular adrenaline. This is because there is inadequate circulation to the muscle, so it will be of no use. You should always follow the guidelines of CPR. In fact, adrenaline might be given in cardiac arrest patients. If the patient is not in cardiorespiratory arrest, you should do the following simultaneously. That's why you should always call for help. So, you'd start by doing an ABCDE assessment and remove any trigger that has caused the anaphylaxis. Now, this is if it's known. For example, if you're given infusion of drugs, or if the patient is consuming food that has led to the anaphylaxis. Do not induce vomiting, just remove the food from the patient's mouth. Now, you should also reposition the patient, and this depends on the clinical features. Now, if this is primarily a breathing issue, sit the patient up. If it's primarily a circulatory issue, lie the patient down with feet up. So this is in this position, such that if the feet are up, blood will flow back towards the heart. And if the patient is pregnant, then lie the patient on their left side. Now, an important drug that you should give is adrenaline, and this is given intramuscularly. Now, the best site to give this in is the anterior lateral aspect of the middle thigh. So this is the front outer part of the middle thigh. So if this is the thigh, and this is the medial aspect and the lateral aspect, divide the thigh into three, upper, mid, lower. So this is the front of the thigh and the lateral part. So you would give the injection at this site. I will talk a little more about adrenaline shortly. You should also establish an airway. If the airway is compromised, you should always call for senior help, as well as deliver high oxygen flow. You should also establish an IV line and give IV fluids. If you cannot obtain an IV line, try to obtain an intraosseous line. You should also give a rapid intravenous fluid challenge over less than 15 minutes, with a crystalloid fluid. You might also give the patient an antihistamine. Now remember we said that the H1 receptors or the histamine 1 receptors are highly involved in the pathogenesis of anaphylaxis. You might also give steroids. Now this is also an anti-inflammatory, and importantly, it is used to avoid biphasic reactions. So a biphasic reaction is a two-phase anaphylactic event. So this means that after the anaphylaxis is treated and symptoms go away, the symptoms might return without the patient being re-exposed to the allergen. So giving steroids might prevent a biphasic reaction. You might also consider giving a short-acting beta agonist, for example salbutamol. Remember that the lungs express beta-2 adrenergic receptors, so activation of these receptors results in bronchodilation. This treatment is also used in acute exacerbations of asthma and COPD. You might also consider giving atropine, especially if the patient becomes bradycardic. However, always consult senior help. Now, the reason why we focused so much on the pathogenesis of anaphylaxis is to give you an idea of the clinical features and what we need to reverse by pharmacological intervention. So remember, we have vasodilation and increased permeability of blood vessels, so we want to reverse this. We also have bronchoconstriction of the airways, and we want to reverse that, as well as swelling and inflammation. Hence why we use these pharmacological interventions. But let us focus on the main pharmacological intervention, and that is adrenaline or epinephrine. Now this is a catecholamine, and is the main hormone produced by the adrenal medulla. Now, adrenaline works on adrenoceptors, and these are the alpha and beta receptors. They are alpha and beta agonists, which means that binding to these receptors activates the downstream signaling pathway. Now, its main effect on vascular smooth muscle is vasoconstriction, and this is achieved via the alpha-1 receptors, so alpha-1. Its main effect on the bronchioles is dilation or bronchodilation, and this is achieved via beta-2. Remember that salbutamol is also a beta agonist and causes bronchodilation. Its effects on the heart is that it increases heart rate, contractility, and AV node conduction, and this is achieved via beta-1. Now, if you remember from your cardiology that beta-1 antagonists reverse all of this, so they decrease the heart rate, contractility, and AV node conduction. So the outcomes that we want to achieve by using adrenaline in the treatment of anaphylaxis is vasoconstriction, this is achieved via alpha-1 receptors, and bronchodilation, and this is achieved via beta-2 receptors in the lungs. Of course, as with all drugs, there are side effects, and these include hypertension, tachycardia, and ventricular dysrhythmias. This is why it is so important that you do not give adrenaline intravascularly. This should only be done by a specialist, as it can cause death. Please like, subscribe, and share our content with your friends and on social media pages. Our mission is to develop need-to-know video content and question banks that remain free for your use. We are unable to keep doing this without your support. Thank you.